Hi, this is Dr. Sajal Kamat, and I am a consultant endocrinologist at Sahyadri Hospital, Pune, and I'm also a panel consultant at Sterling Multi-Speciality Hospital at Nigri, Pimpri Chinchwad. So I'll be presenting a small case. Mr. AB, a 58-year-old patient with a history of type 2 diabetes since 4 odd years, obesity, hypertension, hyperlipidemia, and obstructive sleep apnea. On physical examination, his BMI was 32 kg per meter square, BP of 130 by 82 millimeter of mercury, and a heart rate of 60 beats per minute. His laboratory measurement showed an HbA1c of 8.3%, eGFR of 70 ml per minute per 1.3 meter square, LDL of 69 milligram per deciliter, HDL of 35 with a triglyceride level of 250 and AST of 70 with ALT 100 units per liter. He was on the current medicines, 1000 milligram of metformin twice daily, 40 milligram of lisinopril, 100 milligram of metoprolol, 40 milligram of atorvastatin with 75 milligram of aspirin. Coming to the patient profile, he has a short duration of type 2 diabetes. He's relatively young and has no major comorbidities with no major complications that could reduce his lifespan. He is also at low risk for hypoglycemia. He would benefit from a more stringent goal. So his HbA1c is 8.3% and a more stringent goal would definitely help him. However, he's also obese, hypertensive, hyperlipidemic with obstructive sleep apnea disorder. So what does ADA recommend? It says that less than 7% is a reasonable goal for most non-pregnant adults. In addition to efficacy, following considerations predominant in determining pharmacotherapy for him, such as a risk of hypoglycemia, weight loss or minimize the weight gain, heart failure, atherosclerotic cardiovascular disease, CKD, cost, etc. So these are certain things we need to keep in mind. So Mr. AB is willing to start another medication, but is concerned because he sometimes forgets to take his pills and fears that additional pills will only make his thing worse. He does not want to have injectable therapy. So in this case, what would help is a fixed dose combination. FDC may improve his adherence by once daily dosing, less complex treatment regimens, fewer number of pills, improved side effect profile, and adherence. People with type 2 diabetes commonly live with multiple comorbidities, among which hypertension and cardiovascular disease are the most common. So monotherapy cannot generally address these multiple defects and often leads to failure to maintain glycemic control over time. Current diabetes guidelines encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment. What is ADA recommendation? In appropriate high-risk individuals with established type 2 diabetes, the decision to treat with a GLP-1 receptor agonist or a SGLT2 inhibitor to reduce the MACE, heart failure, CV death, or CKD progression should be considered independently of baseline HbA1c or individualized HbA1c target. So empagliflozin and linagliptin is available as first-in-class treatment in SGLT2 inhibitor and DPP4 inhibitor combination group of drugs. SGLT2 inhibitor is a class of novel oral glucose-lowering agent that mediates the glucose-lowering action by increasing urinary glucose excretion via inhibition of the SGLT cotransporter 2 in the proximal tubule of the kidney. The salutary effect is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of disease course. DPP-4 inhibitor exerts its glucose lowering effect by the elevation of incretin hormone. So it is called an incretin-based therapy. And subsequent augmentation of glucose-dependent insulin secretion and inhibition of glucagon release as well. So combination of these two agents has potential to show the additive glycemic control due to their complementary effect. In fact, the EMPA-REG study reported that the 3P MACE outcome occurred in a significantly lower percentage in the EMPA group compared to the placebo group on top of standard care. In addition, what about the CV safety of linagliptin? That was further elucidated in Carmelina and Carolina trial. HbA1c decrements by EMPA-LINA, the combination of 5 and 25 milligram, has demonstrated 1.81% HbA1c reduction at HbA1c baseline of more than 8.5% at 24 weeks in metformin treated groups. These benefits on glycemic control were maintained at even week 52 in metformin treated individuals, and a higher percentage of patients achieved HbA1c target of less than 7.0% for the combinations. The combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitors that we see commonly has been reported when a DPP-4 inhibitor is added to it, perhaps because of a better glucose control, although other possible mechanisms as to why this genital infection incidence is reduced, the mechanisms need to be investigated yet. To summarize, EMPA-LINA combination provides robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal HbA1c of less than 7% compared to individuals' agents, and also confers a low hypoglycemic risk. Thank you.